Hello, good evening. Welcome everyone, and thank you for joining us tonight for session 1 in our series, The Science and Practice of Paediatric Weight Management. Tonight's session topic is Clinicians' Guide to Paediatric Obesity Care. My name is Charles Broadfoot, and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we work and live on, pay my respects to elders past, present and emerging, and also welcome any of our Aboriginal friends and colleagues who may be joining us online. Tonight's session is being recorded, and the recording and slides will become available from tomorrow in our PHN Education Library. So to access this, you just head to our homepage, thephm.com.au, and click on the Education tab. So we will be using Slido tonight for our polls, questions, and the session evaluation survey. So you can access the polls and Q&A tab on the right-hand side of your screen if you're watching on a computer or laptop. Alternatively, you can head to slido.com, that's SLIDO, and enter the event code for tonight, which is PWM1. So that stands for Paediatric Weight Management and the number 1. A third option is by scanning that QR code that's just popped up on your screen. So please keep an eye out on your polls tab tonight. Our first presenter is launching about 5 polls, and we'd really love your input and interaction with that. So please keep an eye out to answer those questions. And if you have questions of our presenters, we are accepting these throughout the presentation. So please type them in under the Q&A tab. But please note we have allocated some time after the main presentations for a panel discussion. It's now my pleasure to introduce tonight's facilitator, Dr. Natalie Lister. Natalie is a Senior Lecturer and National Health and Medical Research Council Early Career Fellow with the University of Sydney. Natalie is also an accredited practicing dietitian. So thank you again for joining us tonight. I'll now hand over to you, Natalie, to introduce the session and tonight's speakers.
Great, thanks Charles. So welcome everyone for this session. This is part of a 2-part series. We'll be doing a second series seminar in a couple of weeks' time. This title of this session is around the science and practice of paediatric weight management, and we're very fortunate to have 2 very experienced clinicians to speak to us tonight. We have going to be taking a medical lens look at paediatric weight management, and our first speaker is Professor Louise Bauer, who is a paediatrician at the Children's Hospital at Westmead and an internationally renowned childhood obesity researcher. She's also the president-elect of the World Obesity Federation, and her research has helped define the management and prevention of childhood obesity both in Australia and internationally. We also have Dr. Richard McGee, who is a paediatric endocrinologist and treats children and adolescents with endocrine disorders, diabetes and obesity. And he's recently become the site lead for the Central Coast LHD for the NHMRC funded Fast Track to Health study. So without further ado, I will hand over to Louise Bauer. So Professor Louise Bauer, thank you.
Thank you very much, Natalie. And I will just now share the screen. And I think that's what you should be able to see now. Hello, everybody. It's great to be able to talk to you about this really important issue of the assessment and management of child and adolescent obesity. I just want to start by reminding you that obesity is or can be a serious chronic relapsing disease, and it affects about 1 in 4 children and adolescents. That is, overweight and obesity affect that number, and about 8% of school-aged children and adolescents actually have obesity. It's more prevalent in those who experience social disadvantage. So I'm going to address the issue of what form of assessment is required of the child or adolescent with obesity, and what are the approaches to management of obesity in children and adolescents. So I want to start by asking, can you recognise risk? Now, make sure you've got your Slido ready, because I'm going to start asking questions. So what you can see here, and you can start filling in the questions, Now, already for that very first one, can you see risk? Are any of these children affected by underweight, healthy weight, overweight, or obesity? So just see if you can. So what I'd like you to do is, there's case A. Is that boy underweight? Does he have a healthy weight? Does he have overweight, or does he have obesity? What about case B? We'll come on to that. I think we're waiting for people to answer that. So please fill in that question there so we get a bit of a sense. What do you think is happening with that boy there? And then we'll go on to case B. I think I understand right, Charles, that we can't. We go on to case B then, and then you folk can actually fill in and just think, well, what about this girl? Similar age. Does she affected by underweight, by healthy weight, by overweight, or by obesity? And again, fill that in so we get a bit of a sense of what's going on. What if you just looked at these children? What would you think? Because often we just have the eyeball assessment. And then I want you to, when you have time, turn to case C and then make the same assessment of that girl. So just by looking at these children, can you see risk? And I think that's what we often tend to do. And we'll wait for the Slido responses to come in, because we can then start to look at them and get a sense of how they're lining up. And when those are in, then I think I should be able to talk about the summary of all those results for all of you. Now, I may be looking at the wrong spot here, so I may not be able to see all of those, Charles. Oh yes, so what we have here for that very first boy, I think most people thought he was in the overweight range. Now, when I think I can come to this now, if I go to the responses, that boy actually fits in the obesity range, folk. I think you can see that there. When you actually measure BMI, you can't always tell by looking at it. Most people, when we do this, think that he is in the overweight range. What about the girl in the middle? Do we have any results for her? And can we look and see what people think she is? Indeed, quite a number of people think she is in the healthy weight range, but a number of you think she's in the underweight range. And in fact, she does fall in the healthy weight range if you actually measure BMI. She's on the 10th centile. That's okay. 10% of kids are supposed to be on the BMI of 10% or below. But a lot of people looking at her might have thought she was in the underweight area. And if we move to case C, the girl on the right-hand side, many people, when they look at this, so a number of you thought she was healthy weight, about equivalent numbers, and those who thought she had overweight. And she actually has a BMI that's between the 85th and 95th centile. So she is in the overweight range. One of the issues I want to highlight here is that you can't always tell. You need to measure height and weight and plot on a BMI for age chart. So let's go and have a look at this. Here's a girl, age 6. I've calculated her BMI. She's got a weight of 33 kilograms. Her BMI is 22.9. When you measure her BMI for age and plot it on a BMI for age chart, it's above the 95th centile for age. We would say she was in the obesity range, or you might say to the patient, she's well above the healthy weight. And one of the issues you'll recognise is that actual BMI would be in the healthy range for adults, but she clearly is well above the healthy weight when you put it on the BMI for age range. Now, one of the lovely things about children who are still growing prepubertally is that they can change height. This girl took part in a family-focused lifestyle intervention. Her weight was unchanged over the next 6 months, but her height grew 3 3 centimetres, and she had a decrease in BMI as shown there. So weight maintenance may have an important impact on BMI in still growing children. What about central fat distribution? We know that that's important in adults. Central fat distribution is associated with increased cardiometabolic risk. Well, one of the easy to calculate ratios is the waist to height ratio, and that's actually really good for people anyway from about 6 years or above. Our group has certainly done work looking at that. We use that as just one of the strategies just to have a simple measure of central fat distribution. So just think about keeping your waist to less than half your height. So the practice points here are to measure height and weight routinely, to plot BMI on a BMI for age chart, and to recognise that the waist to height ratio is useful for almost all age groups. You may then think, well, how can I raise this issue? It's a highly sensitive issue. How do I just dump it on this parent or this young person? So imagine if you're seeing a child for an apparently unrelated reason, asthma, otitis media, and you think the child may have a weight issue. So the question people often say, well, how do you raise the issue? What are the difficulties in doing so? And when I normally ask this, I'd ask people in person about what you think the challenges might be, and people have a lot of concerns because it's sensitive. And what I want to highlight is that clinical practice guidelines recommend routinely measuring height and weight, calculating BMI and plotting on the growth chart, and then discussing the growth chart sensitively with the parent, or if you happen to be talking to a young person, the young person directly. An adolescent. So you might use language like this for the girl that we were talking about before. I've plotted weight adjusted for height here on the growth chart. You can see that it's above the healthy range for age. Does that surprise you? Would you like to discuss it? Maybe we could make a time to do so. You could then recommend a further consultation to start addressing the weight issue. The point here is that the growth chart is the actual springboard for talking about the weight status. You should also think, well, could the primary reason for the consultation be related to weight? And sometimes asthma or enuresis or a fracture or lower limb pain or sleep disturbance could all be associated with increased weight, and in which case you might want to highlight its importance. And you might also want to think, are there existing problems associated with excess weight gain? And you might want to start to explore and investigate those. So the practice point here is to use the growth chart to raise the issue sensitively. If it's part of your routine practice, it's much easier to raise it. Then think about whether your patient is above a healthy weight. Now, many of you want to say, look, I'd really like a little bit more resources here. And I want to just point out a really great website that's been made available by New South Wales Ministry of Health, the Healthy Kids for Professionals website. I'll come back to it again later on. It's been developed by a whole lot of clinicians in New South Wales. And there are some great videos about raising the issue, offering support to make positive change and this is done with active parents. You might then say, well, okay, but the issue of weight stigma, I'm aware of it. How do we deal with this in my practice? I'll just remind you about weight stigma. It's commonly experienced within health services, and unfortunately, it's commonly delivered by health professionals. And people who experience weight stigma have a lot of negative social, psychological, and health consequences. It's not at all helpful. And so it's something to be avoided. So when you're thinking about your own practice, you might want to think, well, can I, as a medical practitioner, role model supportive and unbiased behaviours towards patients with obesity? And can I role model that in front of my colleagues, other staff, in front of the families, the patients that I see? Think about the language and word choices that you use. Can you use neutral word choices? So words like unhealthy weight or BMI or above healthy weight or weight actually are heard in a better way by most patients than words like obese or extremely obese or fat. Sadly, I have a number of parents who've told me that when they're told that their child was obese, they thought that the doctor was saying that they were beasts, B-E-A-S-T-S. So that's particularly tricky thing to be able to do. It just does not communicate. you also need to think, do we have a safe and welcoming practice environment? Is it a place where it's okay for people who are big to come? Are the staff welcoming? And do I have an empathetic approach to behaviour change counselling? All of those things will make such a difference towards the person, the young person, or the family with obesity. So please think about the language and tone you use. Consider how your practice can provide a safe and welcoming environment for people with obesity. Now, another question is, when should I do clinical investigations in the child or adolescent with obesity? And the general rule of thumb is the older the child, particularly the adolescent, the more likely you are going to do them. If they've got higher levels of BMI, especially central obesity, if there are clinical suggestion of complications such as acanthosis nigricans, if you're dealing with higher risk ethnic groups, which is actually many ethnic groups, and if there's a higher risk family history. So if lots of family members have type 2 diabetes or premature heart disease, you're going to be more alert. And what might you investigate? Well, I think fasting blood tests are really great if you can do that. Fasting glucose, please check liver function tests, look at lipids. If you're going to do thyroid function, do it once, but not every time. Where I work, we're interested in fasting insulin and, we're interested in doing that, but not everybody necessarily does that. So there is some variation in consensus guidelines about that. You may want to do other investigations such as hemoglobin A1C or an oral glucose tolerance test when your suspicion about type 2 diabetes or prediabetes is high. A liver ultrasound, reproductive hormones in females. Iron deficiency and micronutrient deficiencies can occur in young people and children with obesity, and so you might want to look at those. And you may want to consider sleep assessment, particularly in those who may have snoring or pauses or are very sleepy. Now I want to come to a case study. Peter, aged 15 years, of Greek ethnic origin, a high BMI of 36. You don't need to plot that. You can tell that it's high. A high waist to height ratio. He has acanthosis nigricans and a strong family history of diabetes, obesity, and sleep apnea. And this is his results of investigations. And one of the things I want to highlight here is that you can see that he has this classic dyslipidemia we see in insulin resistance with the high triglycerides and the low HDL cholesterol. He has a high fasting insulin, a high insulin to glucose ratio, but he doesn't actually have impaired glucose tolerance on the OGTT. He's got a raised ALT, and that's classically the one that's raised in fatty liver disease, and he has a fatty liver on ultrasound. And so this poor kid who's 15, yet to end high school and go into the workforce, already has central obesity with dyslipidemia, insulin resistance, and non-alcoholic fatty liver disease. So it is of concern. So if we think about investigations, think about high-risk family history, high-risk ethnic background, severe obesity, and clinical assessments suggestive of comorbidities. And of course, I just want to highlight, please assess and treat comorbidities. That obviously needs to occur. I'm not going to focus on that today. What about the basic approaches to treatment? I want to just start. You need to think about the aims of treatment, first of all. They could be a reduction in weight and weight-related outcomes, and a lot of people are keen on that, and that may be an important issue. In the still growing child, a change in weight gain trajectory may be important. So like that 6-year-old girl that we talked about, you may be able to gain some change in BMI just with a child who's still growing in height. Clearly, for most people, you want an improvement in obesity-associated complications, and that itself is going to be vital, as will change in markers of future health or psychological or social complications. But often there's a mismatch between what I as a clinician might want to have happen, what the young person might want to have happen, what the family might want to happen, and indeed what may be possible or what resources may be available. And it's really important to try to get people on the one page there. Make sure you don't just treat yourself, but actually, because I've found that very easy to do, but to treat this family and the young person. Now, I want to come on to the elements of weight management, and I want to highlight, as I mentioned before, we're not going to cover the management of obesity-associated complications as such today, and I'm going to let Richard talk about more additional therapies, or the dietitians talk about additional therapies in more detail, I want to just focus particularly on standard weight management approaches just here now as I talk with you. So there's actually now 6 separate Cochrane reviews looking at this area, and overall they show that there are small to moderate reductions in body weight status for most behaviour change interventions, and multi-component behaviour change interventions appear beneficial, but it's modest to moderate for most of those. But some people respond well, some people less so, and that's, to some extent that's related to the level of engagement and the level of support you can provide as well. I want to show, this is the forest plot from one of the Cochrane reviews. This is for children aged 6 years or less. I think you'll be familiar with Cochrane reviews where you can see the difference between the intervention, in this case a multi-component intervention, versus on the right-hand side the control intervention, and you can see that, and what you can see is that the diamond there shows at the end of intervention there was a small but significant reduction in BMI, for BMI Z-score in this case, for children who took or who took part in the intervention, and indeed 6 to 8 months after the intervention there was still a reduction in BMI Z-score. And one of the things that we notice in children in particular, as opposed to adults, is that there is likelihood for longer term outcomes compared with adults. But of course there are real barriers to providing behavioural treatment in real life clinical settings. I work in Western Sydney, and many of the families that I see will be living with poverty, and so we have to think about budget conscious approaches to weight management, to actually being realistic about what can be provided. Many of our families are culturally and linguistically diverse, and we need to think about culturally appropriate types of interventions, about being able to communicate in languages that are relevant to these families, that they can understand. We may have children, sometimes parents, who have learning disabilities and developmental disorders, and again we need to make messages and approaches that are relevant for that level of intellectual ability. Some of our families, parents, have low literacy or even illiteracy, and we need to minimise written information and actually use simple diagrams or photographs or phone support to support them. Some of our families will be living in various sorts of crises. Of course, we can see that very frequently these days in our COVID world, or living with psychiatric disorders, and for those, they may require individual case management until the crisis or the acute issue resolves before you can actually deal with the weight management issue. Plus, in many regions of our lovely state and country, services are often poorly resourced. They may not be publicly funded or as accessible as we'd like, and some health professionals may be inadequately trained. So it's actually very challenging for in trying to deliver services for such a common health issue. Now, I'm going to not cover bariatric surgery, drug therapy, and other more intensive interventions. They're going to be covered elsewhere, both later today and in a couple of weeks' time. But I do want to come back to some core messages that you can use either for anticipatory guidance or for treatment of families who have overweight or obesity. So these are the 8 healthy habits. They're again on the Healthy Kids for Professionals website. They're freely available. Anyone can use them. And this particular bit of the website is really, really useful. At the Kids Hospital, we use these all the time. Lovely, and they're available in 13 community languages. And it's been used in lots of different settings. So these are the sort of messages: drink water, 2 fruit, 5 veg, have a healthy breakfast, know your portion size, choose healthy snacks, keep your screen time in kids over 5 to less than 2 hours a day. Very challenging at this time. Be active for at least an hour a day, every day, and get enough sleep. And of course, in the middle, be healthy together. So those are the core messages we would use. Okay, and I would recommend having this and just having that available. And you can use that independent of weight status. This is just a useful anticipatory guidance message anyway. Now I want to come to a case of Anna, a 26-month-old Chinese girl. She's being seen for otitis media. I put her height there and her, so she's 92 centimetres on the 97th centile. She weighs 19.8, just over the 97th centile. Her BMI is quite high at 23.4, and you can see it on the BMI for age chart there. And I'll give you some more history. Her weight has tracked along the 90th centile to 6 months of age, and then it started to veer above the 97th centile from 12 months of age. And then you get the history, and she eats the same food as mum and dad and her older siblings, but which includes 3 fast food meals a week, several treat snacks each day, large rice intake, soft drinks. And she does a lot of playing she goes outside and she sits in the sand pit rather than active play, and she has a lot of screen time. Both of her parents have mild obesity, and her siblings are above a healthy range, and 2 of her grandparents have diabetes. And I want you to go to slide 0 now, and I want to ask you the question, and there's no one right answer here, but we might want to just reflect on that. When would you raise the issue? She's coming with her otitis media. You need to treat that, but you are treating that. But when would you raise the issue of Anna being well above a healthy weight? At the end of the consultation? At a later consultation? Or possibly not at this stage? So just think about that. And it may depend, and maybe there's only one or two, only 2 of those are actually exactly where you might do that. I think most of you are saying at the end of the consultation because you listened to what I was saying before. I think most appropriately for most people that will be exactly the right timing for them, because you're there, you're able to raise that in a way that's very sensitive. It might be that there's enough to do about the otitis media. You say, can you come back later? I want to talk about further issues. And that would be appropriate too. You've got to judge the right experience, the right timing. Now, I want to give you in the next one, which of the following would you prioritise with the family? And you can choose more than one of these. Would you change from soft drink to water, decrease the rice portion sizes, have healthy snack options, decrease the screen time, limit the fast food intake, more outdoor play, or something else? And actually, as I asked that, I'm thinking, oh my goodness, that's a bit change. And which ones of those would you actually prioritise to start with the family? And you could actually have a couple of answers for that. Well, you can have several answers for this. I don't think there's, when I was putting this together, it was really, I normally use this to engage in conversation with people. Interestingly, I'm just thinking a number of people have seemed to be putting down change from soft drink to water. That's one of the things I would do, because there's nothing nutritious about soft drink. There's a whole lot of other immediate health benefits to kids from moving away from soft drink, like decreasing dental caries risk. And you know, that should be fairly doable and is a much more discreet thing to be able to do. But you may well be able to, depending on the family, explore some of those issues and try and work out, well, maybe this is a really rice-friendly family, and maybe decreasing rice portion sizes could be a way into making apparently minimal changes that may have more of maximal effect. So, folk, I think you could say all of those at some stage may be things that we'd like to try to intervene with. And no one of those is necessarily the best response. It may depend on the family, but I do think the soft drink is a really great starting point. Now, in this case, the GP sensitively used the growth chart to raise the issue of the weight, encouraged a whole family approach to lifestyle change. The practice nurse, as well as the GP, saw the mother on a few occasions over 6 months. And there were a number of changes that included, and they used the Healthy Kids for Professionals information. So all of the children were offered water instead of soft drink. There was a reduction in serve sizes at the evening meal, including rice. They had healthier snacks offered, and they had more family rules around TV and tablet time. And the kids were encouraged to play outside more often. The sandpit was covered, so she had to run around. And later on, her weight had improved, and her BMI was now 21, but there'd been a marked, so it was still above the 95th centile, but a marked 2.4 unit decrease. You might then say, well, what then do we do? Is that it? What I suppose I want to do, I think there's a role for you initially supporting families, particularly those who've got mild to moderate obesity rather than more severe obesity. You need to think about what fits your skill set and practice and local resources. When you are offering support for families like that, someone needs to provide regular follow-up initially. It's none of this, do this and I'll see you in 6 months' time. So think about phone coaching, SMS reminders, the practice nurse, referral to other therapists such as a dietitian, maybe a clinical psychologist or an exercise professional or some other medical person. Think about a chronic disease management plan and really keep on monitoring the behaviours, and in those who are treatment seeking, monitoring weight. Of course, we need to recognise that we're all part of a more complex health system, and if we think about the chronic disease care pyramid, primary prevention and health promotion are at the base, and then there's a pyramid of care above that, where the vast majority of people with, in this case, obesity can be managed in primary care by GPs or other primary care or group programs, and then those with more significant illness would require secondary or tertiary level care, and in fact bariatric surgery would fit in at the top there as well. So all parts of the pyramid are needed, and you need to think, what's available in this region? I need to know what's available in my area. So I want to encourage you to use the 8 healthy habits and related resources and consider how you can ensure frequent, regular follow-up and monitoring. So that could be by yourself, by your practice, or by other health professionals. And I'll encourage you to identify local referral pathways. Now, Richard very shortly will be ticking up on some of these issues. I want to finish by acknowledging a whole heap of wonderful people and by giving you again the Healthy Kids for Professionals website, where there's a whole heap of resources that I think you would find very, very useful. And I want to say thank you. Now I'll finish now and head back to Richard. I think that's right. I think I will go on to Richard and let him take on the rest of the presentation. Thank you.
Thank you, Louise, and thank you to the Primary Health Network for having me here this evening. My name's Richard McGee. I'm a paediatric endocrinologist based at Gosford Hospital on the Central Coast, and I'm a clinical academic at the University of Newcastle. Unfortunately, I don't have any polls set up in Slido like Professor Bauer, but I would encourage engagement and participation with the audience, so please make use of the Q&A function on Slido. I can see there is one question there, which we might come back to at the end of my talk. And I'm going to share my screen now. So hopefully you are now seeing my slides. Okay, great. So I'm going to follow on I guess from a pediatric endocrine perspective about child and adolescent obesity. First off, I would briefly to acknowledge country, in particular the dark young people, which the Central Coast Clinical School, where I'm working from, is based. The Central Coast Clinical School is one of the urban clinical schools at University of Newcastle, and we run the JMP across a range of clinical schools in the region. Central Coast Clinical School takes about a third of the cohort, and recently the new Central Coast Clinical School and Research Institute opened. You can see some pictures of the building there, and it's a state-of-the-art facility, and it means we also have the ability now to conduct some clinical research studies on the coast, which is a fantastic resource. I wanted to focus on three main topics: the endocrine and genetic causes of obesity, the medical implications, in particular endocrine focus of obesity, and then on treatment. First off, starting with the endocrine and genetic causes. So in fact, most obesity is lifestyle related, and if you're a betting person and you saw a child with obesity, you could be fairly safe in putting your money on the fact that it would be lifestyle related. Even those that are endocrine or genetic related do need lifestyle to facilitate the expression of obesity in many cases. There is an algorithm here which can help guide you through that process of thinking about the cause of obesity, and syndromal obesity, i.e. genetic endocrine causes, really there is usually some abnormality on the history or physical examination that makes you think that they have particular characteristics that will suggest a cause. And if that's not the case, you're likely dealing with a simple primary obesity. There was a cohort study from the 2000s, followed almost 1,500 children from the age of 4 to 16 years, and they were obese, referred to an endocrine clinic for an evaluation, and a syndromal or endocrinologic disorder was only diagnosed as the cause of obesity in 13 out of those patients. So that's less than 1%, and meant that 108 children actually had to be referred to the endocrine clinic for evaluation to pick up on one syndromal case. And all of those patients had clinical findings, and so none of those were actually picked up as a syndromal or endocrine cause just based on laboratory tests alone. So they had clinical findings there. Prader-Willi syndrome is probably one of the more common genetic conditions to be aware of that may cause obesity. You have a picture there of a boy with Prader-Willi syndrome. On the right is a painting of a child suspected to have Prader-Willi syndrome from 1680, and she was brought to the Spanish court at the request of the king. They were fascinated by her size at a young age, and it was interesting that Professor Bauer mentioned that some parents mishear the word obesity, because the word they use to describe this poor girl is the monster, and this painting is called The Monster Nude, and there's another painting of her called The Monster Clothed. So Prader-Willi syndrome affects about 1 in 10,000 to 1 in 25,000 live births. In utero, they have decreased fetal movements, but then in the first couple of years of life, they are quite hypotonic. That persists, but there's a failure to thrive initially, and often they're actually underweight before subsequently switching over and becoming overweight. They characteristically have altered temperature sensation, hypogonadism or cryptorchidism, growth hormone deficiency, and short stature. And growth hormone is now one of the main treatments that we use for Prader-Willi syndrome. They have a developmental delay, actually have decreased caloric requirement, but increased appetite, and so that contributes to the significant obesity. They have absent satiety, so they don't easily get full. Temper tantrums, often in relation to food restriction, and classically an inability to vomit. Other genetic causes that you might think of, so we mentioned Prader-Willi, but Bardet-Biedl syndrome, Down syndrome, Alström, Carpenter, Cohen, Albright hereditary osteodystrophy, and monogenic forms of obesity, all fairly rare, less common apart from Down syndrome than Prader-Willi. And you might consider it if there's non-familial facial features, a developmental delay, deafness, hypotonia, craniosynostosis, or syndactyly. The endocrine causes for obesity, people think about hypothyroidism, and I'll speak a bit more about that in a moment. Cushing syndrome, either exogenous or endogenous steroids might be contributing to that. Growth hormone deficiency, pseudo-hypoparathyroidism, and CNS disorders or hypothalamic obesity as a result of either tumor, surgery, or trauma. You might start thinking about an endocrine cause for obesity if you see short stature, cold intolerance, or short fifth metacarpal or peripheral field defects, or a history suggestive of a hypothalamic disorder. So hypothyroidism is interesting in that often people consider it as a cause for obesity, and many people try and blame their hormones for the obesity. But the role of thyroid hormone is in a broad range of areas, not just metabolism, but thermogenesis, food intake, and fat oxidation. And in obesity, we most frequently actually see a slight hyperthyrotroponemia and a moderate increase in free T3. And there's debate as to whether that's a cause of obesity or as a consequence of the obesity and the body's adaptation to the obese state. And you might have heard of the Choosing Wisely campaign. The American Academy of Pediatrics in 2017 actually said to avoid routinely measuring thyroid function and or insulin levels in children with obesity because of this frequent finding that they may have slight hyperthyrotroponemia, which is likely not contributing to the presentation, and trials of treatment haven't shown any great effect in terms of weight. Just a little bit about hypothalamic dysfunction. Some of the features you might notice in that kind of scenario are behavioral changes, a disturbed circadian rhythm and sleep, given the role of the hypothalamus in sleep cycle, regulation, daytime sleepiness, imbalances of regulation of temperature, thirst, heart rate, blood pressure, disturbances of appetite regulation and satiety, and hyperphagia, which is how we end up with or one of the things contributing to weight gain, as well as a reduced energy expenditure. So both of those contributing to rapid weight gain, which is unresponsive to conventional lifestyle modification. There's an example of an MRI of a craniopharyngioma causing hypothalamic injury-associated obesity, and the syndrome might actually present afterwards so following treatment of a tumor, following neurosurgery or cranial irradiation. You might end up with subsequent hypothalamic injury, or might be due to a glioma, meningioma, astrocytoma, teratomas, or the brain tumors you might get in that region, or metastasis, or an aneurysm. And like I said, you get a lack of satiety, hyperphagia, reduced activity, and sleep disturbances, which might trigger you to think about a hypothalamic cause. So I won't discuss the treatment of hypothalamic obesity further because it's fairly specialized. All right, that's the first section where I talk about the endocrine and genetic causes of obesity, and I wanted to move on to the medical implications of obesity now. This slide summarizes some of the complications that you might find, in particular for children. So there are psychosocial complications such as self-esteem issues, pulmonary issues like sleep apnea, gastrointestinal issues. We already saw non-alcoholic fatty liver disease, renal issues, some musculoskeletal type issues, neurological. You also get dyslipidemia, hypertension, and endothelial dysfunction and cardiovascular disease. And of particular interest to me is the endocrine complications such as type 2 diabetes, precocious puberty, polycystic ovary syndrome, and hypogonadism. So just thinking about the spectrum of insulin resistance and hyperlipidemia, in more severe cases, type 2 diabetes or polycystic ovarian syndrome. Sometimes actually the children with excess weight can have an accelerated linear growth or an early puberty, which might contribute to that. And of particular concern is the child who is short and overweight. And that's one of the times you might be thinking about an endocrine cause or a genetic cause for the obesity. So what is insulin resistance? Because it's something that we commonly come across with a child who is overweight or obese. The impaired ability of plasma insulin at normal concentrations to adequately promote peripheral glucose disposal, suppress glucose production, and inhibit VLDL output. And it's inferred on clinical evidence. So we screen for it using fasting insulin levels or glucose values, but we confirm that with an oral glucose tolerance test. I'll talk about that in another few slides. And there's this progression. So we go from a state of excess food and reduced exercise causing obesity, and that's leading on to insulin resistance, higher BGLs, then impaired fasting glucose, subsequently becoming impaired glucose tolerance, and that impaired glucose tolerance leading to cell damage of the beta cells in the pancreas, and insulin resistance, subsequently insulin deficiency and diabetes. So 24% of adolescents with impaired glucose tolerance will actually go on to develop type 2 diabetes in less than 2 years. So you can see it's a progression. So oral glucose tolerance tests for children, I'm sure you are well aware of how they're conducted in adults, but just as a quick reminder, for children, we use an unrestricted diet, including carbohydrates for at least 3 days before the test. Normal physical activity, the child should otherwise be well. They need a 10 to 16-hour fast, so that equates to about fasting from about 9 p.m. the night before. And then they get a 1.75 gram per kilogram glucose load, up to a maximum of 75 grams, which has to be taken less than 5 minutes. And in children, we often do insulin and glucose levels together before and 2 hours after the glucose load, but sometimes other bloods, depending on whether you're considering a metabolic cause or otherwise. The cutoff values for what is normal, abnormal, and in between are available on the ISPAD guidelines, but pre-diabetes, diagnosed according to the American Diabetes Association definitions, impaired fasting glucose, or IFG, is defined as a fasting plasma glucose, FPG, greater than 5.6 to 6.9. So impaired fasting glucose is 5.6 to 6.9, and then impaired glucose tolerance test is after after a carbohydrate challenge. The glucose is 7.8 to 11.1, and the HbA1c range there is 5.7 to 6.4%, which has to be a laboratory-based HbA1c, not a bedside. In obese adolescents, it's important to note that pre-diabetes is often transient. So the normal pubertal development actually induces an insulin resistance due to hormonal changes, and 60% will revert to having a normal OGTT within a couple of years after puberty has ceased, as the insulin resistance of puberty wanes. So that's something to keep in mind. This is taken from the ISPAD guidelines from 2018, showing the criteria for diagnosis of diabetes mellitus. So when do they progress from having just impaired fasting glucose to glucose tolerance to diabetes? You can see here if they have the classic symptoms and a glucose greater than 11.1 or a fasting plasma glucose greater than 7 on 2 separate occasions. That's what that little asterisk there is for. Or following an OGTT, the 2-hour post-glucose would be greater than 11.1, or HbA1c greater than 6.5%, although the use of the HbA1c criteria for children is less defined than in adults. And then metabolic syndrome, the definition of that is fairly clear for adults, but for a long time in pediatrics, it wasn't so clear, and there was some variability depending on which guidelines you were reading. This consensus statement from 2007 tries to take into account all the different guidelines that predated this. And essentially, to have the definition of metabolic syndrome in a child, you need to be thinking about abdominal obesity plus 2 or more of the following components that you can see in the table. So obesity based on waist circumference you need, and then 2 or more of the following. So triglycerides, HDL levels, blood pressure, and glucose. And you can see there that they've broken it down into different age groups. So that those children less than 10, 10 to 16 years and above 16. So above 16, they recommend using the adult criteria, and below 10 years, they actually don't recommend giving a child the diagnosis of metabolic syndrome. So for metabolic syndrome, really, we're dealing with an age range between 10 and 16 years for a child. The fasting plasma glucose levels, if they fall between 5.6 and 6.9, it's suggested then that you go on to an OGTT. I forgot to mention too that at the start of my presentation, I'll be happy to provide a copy of these slides to the audience, so you don't need to worry about writing down these numbers, because I know I'm going through some of this fairly quickly. The prevalence of metabolic syndrome in children, 3%. In overweight children, 11.9%, and obese, 29%. So you can see how that when the weight increases, the prevalence of metabolic syndrome also significantly increases. Here's an example case of an 8.5-year-old girl who actually presented to the dermatology clinic, and because of this discoloration, which you can see around the neck, her BMI at that time was on the 98th percentile. She had severe acanthosis nigricans and a strong family history of metabolic syndrome, early cardiac deaths on both sides of the family. And she, for the last 6 months, had been trying to make healthier food choices. She was dancing, doing sports, trying to lose weight, but unfortunately still gaining weight. And she's 8.5, still pre-pubertal. Blood pressure there is 110/60, and you can see the acanthosis nigricans and the flexures there of the neck. Her waist circumference was 84, so given the height, that was a ratio of 0.6. As Professor Barr mentioned, you want to keep that below 0.5 if possible. So she went on to have an OGTT. You can see at baseline, her fasting plasma glucose there is 4.4, which is fine, but she did have an elevated insulin level at baseline. And then at 120 minutes, you can see that glucose is above the threshold there, and she has still a significantly elevated insulin level, so she has impaired glucose tolerance. Okay, so that's the first two parts of the talk, and now to move on to the treatment, in particular from the endocrine perspective and pharmacological type perspective. Obviously, the main foundation of treatment is, as Professor Bauer mentioned, lifestyle modifications and all the aspects related to that. So this is this section of treatment only applies to a select subgroup. So metformin is one of the medications we consider. It's a biguanide, and it increases hepatic and muscle insulin sensitivity, decreases appetite, a couple of mechanisms for that, and often results in a mild weight loss. It doesn't change energy expenditure per se, but on the right with that figure, you can see how it has different effects. So from the top, decrease food intake and increased leptin, insulin sensitivity. You get increased insulin stimulated glucose uptake in the muscle and fat oxidation. In the gut, increased GLP-1 secretion, some change in gut flora as well, decrease weight in the adipose tissue, and in the liver you get decreased glucose production, decreased fat synthesis, and cholesterol synthesis. So a multitude of effects across the body. This is the latest systematic review I could find on the effect of metformin on weight loss in children. And you can see a large number of studies have been conducted. On the left, you have the forest plot for BMI, and on the right, the forest plot for weight loss. So you can see that it results in a significant reduction in BMI, a statistically significant reduction in BMI and weight. And the studies are fairly homogeneous. Of course, there's some outliers, but on the most part, those results are fairly consistent. It does have side effects. In particular, gastrointestinal side effects are one of the more common. Some of the patients complain about metallic taste and abdominal discomfort, diarrhea in 5 to 20%. So the relative risk of gastrointestinal side effects is around 2 compared to those without metformin. It can cause low vitamin B12 levels with chronic use due to malabsorption, usually not in anemia. Lactic acidosis, which is something probably more seen in adults, but I don't think there's any reports of it in kids, but it's something we consider. And it is contraindicated for those with impaired renal function, heart failure, other forms of acidosis, clinically significant liver disease. So generally we start metformin or consider it in obese adolescents who have evidence of clinical insulin resistance. So things like acanthosis nigricans, PCOS, or hyperinsulinemia. And to avoid the side effects or minimize it, we start with a low dose and and build slowly up over a couple of months is my usual practice, up to a maximal dose of 2 grams per day. Now, I often use the XR formulation because it means that they only need to take that medicine once a day, and that improves compliance. But for some children, those tablets can be quite large and difficult to swallow. They might prefer the non-extended release formulation so that they can crush it or divide it up and make it easier to swallow. Generally, we think about metformin for children above 10 years of age. On occasion, it's used younger than that, but that's kind of an approximate guide. So brownie points for anyone who knows who this group is. I should have set up a Slido for that. It's the new kids on the block, and that leads me to talk about the GLP-1 agonists. And I have to thank Professor Bauer for lending me her slides for the next couple of sections of the talk. So GLP-1 agonists have a range of effects as well. As you can see on the figure, they increase postprandial insulin secretion, reduce glucagon secretion, delay gastric emptying, decrease appetite, and induce weight loss. They are often used as a second-line treatment for type 2 diabetes, and particularly they have an effect on cardiovascular disease. There are different formulations, so those with short half-lives such as liraglutide and longer half-lives such as dulaglutide or semaglutide. They do have a range of side effects too. In particular, nausea, vomiting would be one of the more significant, and a large number of patients will experience that, diarrhea and some others. The mechanism of their action, as you can see on the right, again, crosses multiple systems within the body, in particular decreased gastric emptying. They have an effect on appetite and satiety. The muscle, you get increased glycogen synthesis and oxidation of glucose, fatty acid oxidation or synthesis in adipose tissue, and in the pancreas, increased insulin secretion, decreased glucagon secretion. So I'm just waiting for my slide to come up. I think my internet connection must have slowed down. This is where I shout to my daughter to stop watching videos, using up the bandwidth. Let's go back. So I just wanted to briefly go through one of the few randomized trials that have been conducted today of GLP-1 use for children or adolescents with obesity. So this is not just thinking about type 2 diabetes, but just as a treatment for obesity, because one of the other beneficial effects of GLP-1 agonists is weight loss. So this was a trial published in 2020. It was a randomized trial, double-blind, placebo-controlled trial run by Novo Nordisk across 5 countries. They had a 12-week run-in period and then a 56-week treatment of liraglutide versus placebo, going from the starting dose up to 3 milligrams daily where tolerated, and a 26-week follow-up. Children were aged 12 to less than 18 and a BMI greater than 30, and that was a stable body weight. Type 2, children with type 2 were eligible, but primarily it was a trial for those with obesity. The primary endpoint was change in BMI, and they had a range of secondary endpoints as well. Sample size was over 200 patients. This is table 1, the baseline characteristics, just showing that 82% managed to get up to the maximal dose in the liraglutide group, 98% in the control group. Fairly similar at baseline. And then in terms of efficacy, liraglutide was superior to placebo in terms of reducing BMI. And here you can see BMI as well. So the reduction in BMI of at least 5%. So a 5% reduction in BMI was seen in 43% in the liraglutide group versus 19% in the placebo group, and a reduction in BMI of 10%, which is a sizable reduction in BMI, observed in 26% in the liraglutide group versus 8% in the placebo group. Here's the change in body weight. So same as before, there's a greater reduction for the liraglutide treated group. And this slide, or this table 3, looks at the adverse events during the treatment, and so there were significantly more side effects with liraglutide, such as nausea and vomiting, but most were mild to moderate. And there were 13 people who discontinued the trial in the liraglutide group versus 0 in the placebo group, 1 suicide in the liraglutide group, which was considered not related to treatment. And this reduction in weight is similar to those outcomes seen in the adult trials, but weight gain was seen in the 26-week follow-up period. So once these are commenced, they do need to continue. And liraglutide is now subsequently approved by FDA for treatment of adolescents with obesity. Unfortunately, in Australia, it's not the case that it can be used for obesity, and really the pharmaceutical options available are very limited. This was the most up-to-date systematic review I could find on the use of GLP-1 agonists for children and adolescents with obesity. And similar to what we've seen with the previous trial, which is part of the forest plots here, it causes a beneficial reduction for weight, which is figure A here, BMI, figure B, and the BMI Z-score, figure C. So in the text here, you can see body weight, the mean difference was minus 1.5 kilos across these studies. BMI, mean difference of minus 1.24. The BMI Z-score, mean difference minus 1.4. HbA1c also has a reduction. No change seen with lipid profile for these trials, and increased risk of nausea, risk ratio above 2, so twice as likely to have nausea. Briefly to discuss surgery, this is something we consider in children who are fully pubertal, near final height, so really they've passed their adolescence and are really almost towards the point of becoming adults and transitioning to adult care. Extreme obesity and comorbidities, which persist despite compliance with a formal program of lifestyle modification and or pharmacotherapy. They don't have an underlying untreated psychiatric illness and come from a stable and competent family unit with access to an experienced surgeon in pediatric bariatric surgery, and where they've got the infrastructure for multidisciplinary patient care. These are some of the recommendations that come from the position paper or statement published, I think it was 2010, from the Australian New Zealand Association of Paediatric Surgeons and the College of Physicians. The issue, I guess, with bariatric surgery for these children is accessibility, and these other requirements, to be completed puberty and come from a stable unit, and to be compliant with a formal program of treatment. Often these are many of the barriers, and Professor Bauer probably has more experience. She does have more experience than me. I'm not sure how many cases over the years she would have dealt with that ended up getting bariatric surgery. At the moment, I've only got one where it's been discussed, but it's difficult to find surgeons that will do that. There is, to my knowledge, only one trial of a randomized controlled trial of surgery in adolescents for weight reduction, and after 2 years, it showed a very significant reduction in weight versus lifestyle, so 34.6 kilos versus 3 kilos, and in BMI. So it's effective if you can have it, but like I said, not easily available. And I'm sure your own experience with adults is that it's often more readily available in the private system, but hard to often access within the public system. There are several consensus guidelines around the use of bariatric surgery. Some of those are listed there, which might be of interest to you. And some of the common elements across those guidelines is that the child has to have severe obesity. We're talking about BMIs greater than 40 or greater than 35 with severe comorbidities, late puberty or near final adult height, developmentally mature, and able to follow a weight management program for an extended period. So these are patients who are very motivated and able to follow treatment plans, willing to participate in a pre and post-operative treatment program, and understand the implications. So informed consent is also an important part of that, and family support should be optimized. I wanted to mention the fast track trial to health, which Professor Bauer is one of the principal investigators. The website there hopefully will bring you to this site to give you some further information. So it's a trial for children between the age of 13 to 17 years, so adolescents who have obesity, and it's a trial of very low energy diet. So you can see the different phases here. Everyone starts in phase 1 on a very low energy diet, and they have meal replacements each day for 4 weeks. In phase 2, then participants are randomized to intermittent energy restriction dietary pattern, so the 4-3 plan or reduced calorie dietary pattern. And then phase 3 is everyone has ongoing follow-up and support with the dietitian. So this is a multi-site study. It's ongoing and hopefully finishing up recruitment later this year, early next year. We are recruiting patients at the Central Coast at Gosford, but also there are other sites at Westmead and Monash down in Melbourne. The Go for Fun program is one of the referral pathways to be aware of for obese children run by New South Wales Health. This is for children aged 7 to 13 years above healthy weight range in the families. It's usually very well received. Unfortunately, with COVID restrictions, some of the face-to-face events have been cancelled or modified, which has had an impact. For older children, so thinking about parents or family members above 16, the Get Healthy program or telephone-based health coaching would be appropriate. So thank you for your interest and for having me here tonight. The QR code, which you can see there, should allow you to download a PDF of the slides for your information. And like I said at the start, I'd welcome any questions you've got in the Slido session. So I'll hand back to Natalie. Thank you.
Great, thanks Richard, and thanks to Louise too for such a fantastic talk and really interesting presentations. So we do have some questions have come through on Slido, and I encourage you to continue to ask questions because we do have quite a bit of time for a discussion. So Stephen Lindsay has asked, and I think this one will go to Louise. It's about gathering information and that it can be difficult to get the information around family habits, and the question has just disappeared from in front of me, but around family habits, and is it better to leave that to a separate consultation, especially when you don't have buy-in from the family? And I guess that kind of leads me into a question that I wanted to ask about disengaged families, and sometimes you have the silent saboteur of a parent that is potentially not as engaged or as helpful. So I'll pass over to Louise to answer that.
Thank you, Natalie. Yes, thank you for Steve for that question. Of course, you can't go into everything. Often you gather this information over several consultations as you meet with family and talk about different things. I would certainly just rate, certainly in the context of general practice, spend some time raising the issue and helping people think about how much they'd like to engage in actually meeting with you or the practice nurse or somebody else to talk about the issue. And sometimes we actually use that 8 healthy habits to start to, in fact, every time I use it to actually talk with families about these are some of the things that we would recommend taking part in, incorporating into a healthy family lifestyle. Do any of these seem reasonable to you? Are there any challenges for you here? Maybe we could start to talk about those. So yes, you can't get everything in one short consultation, but I think you can start to get a bit of a feel for issues. And often parents will have a bit of an idea about what the challenges might be, what is tricky, what are the issues that they'd like to deal with. And I think as you start to explore those issues and help them deal with something, maybe other issues will come across. It's why soft drinks is often quite an interesting start, because I think a lot of people realise soft drinks aren't just like, aren't necessarily the world's best drink for kids, and they can recognise that there may be other benefits to trying to decrease that. So if you can help families have a degree of control over that, then it may be possible to raise other issues. Natalie also raised the issue about what happens if you don't have a family member or family members who want to engage in this issue. to some extent, you certainly need to take some time raising the issue, having a way of being able to talk with the family members. And I think that's where general practice is in a great situation compared with specialists who will only see, for example, the child rather than the whole family. Strategies we would do, I always ask, now who's the person most responsible for doing the cooking, the buying of the food, who looks after the kids after school? Is it, in a separated family, how much is dad involved as opposed to mum? Is there a grandparent who's actually doing the bulk of the caring? That person needs to be involved. And I would say, can they, if mum and dad do a lot of co-parenting, or if there's a grandparent who's really involved, I'd want to involve them. Now, these days, they'd be they'd be FaceTiming in or something like that because of COVID restrictions on numbers of people and so on. But I'd be wanting to engage them and help them realise about what's going on. And I think sometimes it's helpful if people can actually see the growth chart. They think, oh, he's just big like I used to be. It's why it's nice if there can be a conversation. It's not good to get into an argument or anything like that. It's good to try to open up doors there. In an adolescent, as they start to have a more maturity, self-efficacy themselves, then you may want to support them and think about strategies to help them be able to work perhaps independently of the parents to deal with issues. That's where, if they're 16 and above, things like the Get Healthy Phone coaching line can be really useful. And the Go for Fun group program is actually a lot of fun. A lot of kids enjoy it. So for 17 to 13-year-olds, a lot of families would enjoy that. I'll hand back to Natalie now.
Sure. Okay, great. Thanks, Louise. So there has been a couple of other questions that have come through on the Q&A. So I will reserve my questions that I have and make sure we get to those ones first. So the first question is around, I might actually throw to Richard first, and then we might go to Louise for comments on what your thoughts are around intermittent fasting for teenagers.
Thank you, Natalie. So yes, intermittent fasting diets and energy restriction would potentially form part of the treatment plan for the patient. I guess each situation will be individualized to the particular patient and based on the assessment of what area can be optimized and what's going to be something that's sustainable and that the patient will engage with. So it should be a joint decision between the patient and clinician. The Fast Track to Health trial is obviously one of those where we look at a very low energy diet, and one of the important kind of aspects when you're doing dietary modifications like that is to have some dietitian input, particularly one who has experience within the area. So my suggestion would be to explore the individual's situation, their willingness to participate in a diet like that, and also to get dietitian input to ensure that it's been conducted appropriately. I might pass over to Louise and see if she has anything else to add to that.
Thank you, Richard. I think next week there'll be a bit more discussion from the dietitian. 2 weeks' time, I think the dietitians will actually talk about that in a little bit more detail as well. Completely agree with Richard. I think you need to find what's going to work with that young person and that family. Everyone needs a base of approaching a healthy lifestyle and reasonably healthy dietary intake for everybody in the family. When we do talk about intermittent energy restriction, like what you might know as the 5-2 diet or the 4-3 diet, the days when you're on the fasting bit, you're still having balanced micronutrients. You may well still be having salad, low carb vegetables. You may be having lean meat. So it's not a true, going without food fasting. A lot of what we do is just try to regularize eating patterns in young people. So they still have breakfast, they still have lunch, they still have evening meal. And if they're on a more restricted diet, then that will be nutritionally replete and still have vegetables, etc. You'll hear about that at the next session, but the key message is please involve a dietitian. I do want to raise one issue. People have sometimes been concerned about whether people may develop an eating disorder or similar with a more intensive dietary intervention. I can reassure you in general that a professionally run intervention by a dietitian, by experienced doctors, etc., does not seem to lead to that in treatment-seeking people. In a couple of weeks' time, they'll raise that issue a bit more and talk about it in more detail, but I do want to reassure you in the meantime.
Sure. Thanks. Great, Louise. And I will just, I guess, add and reiterate that there is some emerging evidence for those intermittent fasting style diets, and we will go into that, in a few weeks' time when we talk about the diets for adolescents in particular. So there's another question come through around any particular statistics on the likelihood to develop type 2 diabetes based on BMI. Particularly for these younger age groups. So I don't know who would like to answer that, whether Louise or Richard would like to answer that one. Perhaps Richard?
Thanks, Natalie. I don't have the exact data to answer that question, but I do want to make a couple of points around it. The incidence of diabetes, both type 1 and type 2, is increasing in the population anyway. And we don't see any type of linear relationship between increased weight and type 1 diabetes, but there is with type 2. So as the weight increases, you are going to be thinking that the child may develop diabetes. The specific numbers I don't have available. Louise, do you know of any off the top of your head?
I don't know specific data here for Australia. I do know it's more likely the higher risk the family history. So if a parent in particular or grandparents have type 2 diabetes, if there's acanthosis nigricans, higher risk ethnic group, and the more severe obesity. So I don't think we have quite as clear data as they may have in some subgroups of populations in the US. But that's why it's important to take a bit of a family history and why it's important to examine the child for things like acanthosis nigricans. If I just comment on that, a lot of mums will come and say to me, oh yeah, that dirty neck there, I've been telling them to wash their neck. And then you have to explain that that's actually not poor hygiene, that's something quite different, skin manifestation of a metabolic disorder. And I also have to be careful that I don't make a big show of finding it on someone who may actually feel very embarrassed about having this dark skin. So, I often say things like, well, I just noticed that because I went looking for it, I found it, and this is what it means. So some young people, particularly girls, will be particularly sensitive about that issue.
Great. So coming towards the end of our session, but Louise, do you have any tips for improving engagement with families?
I think this is where GPs have it over every other form of clinician, because you see the whole family on many occasions over many years. I do think the issues that I talked about dealing with weight stigma and language are really important. So I think if you make it easy for the family to talk to you about obesity, if you make them not feel embarrassed or stigmatized, then it's going to be much easier to deal with the issue. It's much easier if you have both parents or the other carers involved, because it's easy for someone to sling off at the back who've not been part of it. I think it's helpful if you have a growth chart and you can print it off and plot where the BMI or the weight is, and they can see that it's, for example, well above the 97th centile for weight or 97th centile for BMI. I think it makes it a little easier for people to realise it's different. Because even when we went through that thing of comparing, thinking, well, does this child have overweight? Does this child have obesity? It's easy for us to under-recognise obesity. And particularly if a child's from a large family, everybody might be quite large, or the kids on the street may be large as well, and they may not be able to tell that there's any difference. I also think that's why I go to family history, and I always talk about diabetes and cardiovascular risk, and well before I get to talking about people in the family who struggle with their weight. So I actually deal with things health issues that people find less stigmatizing. And those are some of the strategies I use to actually start to engage families and thinking, actually, a whole lot of family members have this issue. Oh, there's a family history of type 2 diabetes. I look at the growth chart, and it's not just the doctor saying, I can see that it's well above that range there. And then I think it's really important to hear the voice of the young person. Make it easy, particularly for an adolescent, to talk about how important this is for you. So on a scale of 0 to 10, where 0 is I don't really think about it, to 10 is it's the most important thing. Where would you put dealing with your weight on that? And I often find young people will say 7, 8, 9 out of 10. And I've seen parents get quite surprised by that. So allowing the young person to have a say is really important. Thank you.
Thanks, Louise. I guess one of the burning questions that I have, and I think it's probably the elephant in the room, is around what's happening with COVID. And we've seen so many new media reports around COVID and the relationship with obesity. And I wondered if you would have any thoughts on how COVID and the situation with current lockdowns in New South Wales might be affecting obesity care, particularly.
Thank you, Natalie. Just in terms of COVID, COVID impacts on people with obesity, particularly adults, are much more likely to have severe COVID. And in the US, North America, Europe, those people were much more likely, people with severe obesity were more likely to end up being hospitalised with COVID, to go to intensive care with COVID, and to have increased mortality with COVID. While treatment has improved with people with COVID at the moment, obesity is actually the second most common, most significant risk factor after increased age for severity of COVID. So we need to take it seriously. So if you have patients who might have adults or even adolescents who've got moderate to severe obesity, they should be being fast-tracked for COVID vaccine because they're at higher risk. Now, what does COVID restrictions do for obesity risk? Well, we've got data, again, from the Northern Hemisphere and recently published in JAMA last week, increased prevalence of obesity occurring and overweight in the United States occurring during the COVID year to date compared with previous data. Now, we recognise that where there's been long restrictions, where a lot of people are depressed, stressed, just kept at home, not moving around, on the screen, comfort eating, getting takeaways, you might expect weight gain to increase. And indeed, that has occurred in several studies in adults and now in adolescents in the Northern Hemisphere. In some countries, we see really big changes in food insecurity. And if this goes on, particularly in more disadvantaged areas. So just not good. Another not good reason to have COVID in our community.
Okay, thanks, Louise. I think that's probably all of the questions. There's no further questions coming through on the Q&A, so we might wrap it up. So for our next session, we will have a panel of dietitians speaking about the interventions that are useful to prevent and also manage overweight and obesity for teenagers. So we're going to be specifically looking at adolescents. And we'll also have a series of case studies there. We'll have a very experienced clinical dietitian. So with that, I think I just will wrap up and say thank you and hand back over to Charles.
Thank you, Natalie. Thanks so much for all your help you've given me in setting up this series. I'm really looking forward to the second session as well. I want to take this opportunity to give a really big thanks to both Richard and Louise for not only generously giving your time tonight to present and share your expertise, but also the time that you've taken to prepare your content. So we really, really appreciate it. This session is being recorded, as I mentioned, so the recording and the slides will become available in our PHN Education Library from tomorrow. So if you'd like to rewatch it, or if you have a colleague that missed out, they can definitely watch the recording. So as Natalie mentioned, we do have a second session. So that one is on diet interventions to prevent and manage adolescent obesity. So it's at the same time in 2 weeks. So it starts at 6:30 on Wednesday, the 15th of September. So you can register for that now. The registration link is on the same flyer. I will send this out again, but if you have registered through another means, the easiest way is just to jump on our website and click on the education tab, and we have all of our upcoming events, so you can register that way. You'll also see that the evaluation survey for tonight has popped up in the polls tab. If you could just take a moment to quickly fill that out before you log off, we really appreciate your feedback. So thank you again for joining us tonight, and that's all from me. So I wish you all a safe and enjoyable evening. Good night.